Welcome to In Your Neighborhood. I'm your host, Chris O'Rourke, and we have a special show for you tonight. This is October, and that is Breast Cancer Awareness Month. If you don't have a loved one who's had breast cancer, a family member who has had breast cancer, then chances are very good that the majority of us know someone who has dealt with breast cancer. Right now in the United States, there are 3.8 million of us who have breast cancer, and we're expected to add 276,000 to that number just this year. So joining us today is Dr. Nicole Sharp from Geisinger Medical Center. Dr. Sharp, welcome and thank you for joining us.
Thank you, Chris, for having me. I'm excited to be here.
Okay, let's go way back a little bit. When did you officially become a doctor? How long have you been a doctor?
So I've been out in practice for about 3 years. Those years have all been spent at Geisinger, actually. I actually started here as a general surgeon and built up a robust general surgery practice, including breast surgery. At that point, I really fell in love with my breast surgery patients and wanted to dedicate my practice to continuing to help them and advance the treatment of breast surgery. So I actually took the time to go back and do a breast surgical oncology fellowship where I got additional specialty training in comprehensive cancer care for breast cancer patients, including oncoplastic surgery. And now I am back at Geisinger and continuing to grow a wonderful program that we have here.
So that's a fairly atypical pathway for a breast surgeon for oncology. What is it not?
Well, so for different people, they take different paths, and some people do go back after being out in practice for some time to get additional training. I have always wanted to be a surgeon. That's always been where my passion has been. General surgery, though, a lot of times dealt with acute emergency issues, for instance, appendicitis. So you would see somebody having a really bad day, you take care of their emergency, you check on them after surgery, and it was done. It didn't allow you the opportunity to really establish a long-term relationship with your patient. And you contrast that to my practice now with breast surgical oncology, in that we get the opportunities to meet with our patients at the time that they detect a concern in their breast or at the time when they have a biopsy. And we get to help navigate them and guide them through their full diagnosis and treatment pathway. And that includes not just surgery, but also medical oncology, radiation oncology, if that's included, genetics, survivorship, and even plastic surgery. So it's really much more comprehensive and longitudinal care that I can provide for my patients, which is really rewarding for me.
So how much, just curious, how much has the field changed since you started? 3 years, but I'm sure a lot even in 3 years has changed.
Yeah, absolutely. You know, when I look back into what I learned from textbooks in medical school to how I was trained as a resident to being out in practice, there have been monumental advancements in the treatment of breast cancer. Obviously, I am a surgeon, so I can talk about those specialties, but my specialty in breast surgery goes hand in hand with all the advancements that have been made in the specialties that assist me in the treatment of breast cancer. So as technologies have evolved in terms of breast radiology, breast medical oncology, breast radiation oncology, and genetics, just to name a few, have really impacted how I get to take care of my patients. For instance, years ago, the only tried and true, surgical treatment for our patients with a breast cancer was what was called a radical mastectomy. And that included radical surgery, essentially removal of the breast, the lymph nodes, and led to significant complications for our patients in terms of healing issues, deformity, and swelling or lymphedema of their arm. Now, because our treatments have gotten so much better, minimally invasive treatment options are now available that we offer here. We've moved away from big open biopsies to minimally invasive needle biopsies. We've moved away from removing all the lymph nodes underneath an arm to trying to do selective sentinel lymph node biopsies that really minimize the risk that a woman is going to have swelling or problems in her arm after. And you couple that with the improvements with my breast radiologist, their pictures are better than they've ever been. So they're detecting cancers in an earlier stage, which allows us to give patients a very good option for surgical cure and medical cure and many opportunities. Also, our advancements in medical oncology has also led to significant improvements in our disease-free survival and our overall survival for our patients. So huge leaps and bounds.
So is the mammogram still the first step to take?
Yeah, for most of our patients, the mammogram is one of the first imaging studies to take. Usually it starts with seeing your primary care provider. That may be your family practice or internist or even your gynecologist with a concern that you have. If you're not having a concern and you're just going in for your annual screening mammogram, that is usually the first test that we get.
Okay. And so how many different types of breast cancer are there? You talked about all the different forms of oncology and all the different new treatments for it. So I imagine that as this field has grown, we're uncovering more specific ways to diagnose different types of breast cancer.
Mm-hmm. Yeah, that's a very good question. So we can divide up the number of types of breast cancer that we have in different ways based on how we define it. I would say when I'm usually meeting with my patients, I divide breast cancers into invasive and non-invasive breast cancers. So invasive means it has the chance to spread. It doesn't mean it has spread at that time. Versus non-invasive, those would be like a DCIS or a ductal carcinoma in situ where it has not spread. Those are the most common divisions we see in cancer. But as many people know, there are additional ways that we can divide cancer that give us many different subtypes. Breast cancers most commonly come from either the lobules of the breast or the ducts of the breast. And then there's many additional subtypes within that those can be divided into. Furthermore, sometimes we divide up types of breast cancer based on the hormones associated with those breast cancers, whether that be estrogen receptor positive, whether that be a triple negative breast cancer, or whether that be a HER2 positive breast cancer. And how we define those based on the different hormones really affects what the prognosis is and what our treatment options are for those patients. And finally, we have even more subtypes, including when cancer is diagnosed in an inflammatory setting or when cancers are diagnosed in a metastatic setting.
How difficult is that for a patient to hear all the delineations in their diagnosis so that they can be educated about the disease they have, the form of the disease they have?
Yeah. You know, I think the amount of information that most women get when they are diagnosed with breast cancer can be overwhelming. So here at Geisinger, we really encourage them to bring friends and family with them or dial them on the phone to be on speakerphone with us so that they can have the support and extra ears that they need really to take in the information. We also provide them with lots of handouts and pamphlets that reinforce the numbers and things that we go over in general, and copies of their pathology report to reinforce what we talk about with their specific treatment plan. Here at Geisinger, we have options for a multidisciplinary clinic. So rather than having our patients having to run over from the surgeon to the plastic surgeon to the geneticist and medical oncologist, all of the providers that can provide care for this patient actually come together and meet in one place. So a patient and their family members can come to a single room, and all the providers can take turns going into that room and really addressing their specialty with that patient. And while that's a lot of information to take in at once, it's nice because the patient can walk out of here with a comprehensive view of what their plan is going to be and make sure all their providers are on the same wavelength in terms of what their treatment plan is. So it's really nice to have that option for our patients.
And I think you alluded to this earlier, that it is important for you, and I'm sure it's good for you as a physician, to be involved right from the start and all the way through.
Absolutely. So I'm a surgeon. So in some aspects, I actually am one of the first stops people come to. For instance, if the first thing they feel is a breast lump or breast pain, their primary care provider may come to us, or they may set up an appointment with us directly without going through their primary care physician. However, many times I may actually be the second line of defense, essentially, where their primary care provider may have actually already ordered that mammogram that you talked about, and an image may already have been taken. And in many cases, it may have already been biopsied. So many times a lady is showing up to my office already having a diagnosis of cancer, so that we can kind of hit the ground running at that time in terms of how we can best expedite the treatment for that patient.
How important is the emotional component for a woman?
It's huge. You know, I can't emphasize enough how emotional this diagnosis can be. And you really touched on this, and that 1 in 8 women, so 12% of women get breast cancer. So it does touch all of us in some way, shape, or form, whether it's personally or through the workplace or something like that. And because of that, it is very emotionally charged, particularly if people had somebody have a poor outcome, or say a breast cancer recurrence or a spread, a metastasis of their breast cancer. And there can be a lot of anxiety, and there can be a lot of misinformation about breast cancer. So how I like to approach it is give patients the most comprehensive information that they can have. It's very important to me that they feel like all of their questions are answered, and that they have ways to reach out to their providers to continue to ask questions to us as they come up in their treatment planning. So here we utilize an online patient portal, which is secure, that they can reach out to us. And we have after-hour numbers where they can reach out to us as well with any question or concern that arises, because this is not a short-term relationship that we develop. This is a long-term relationship that we have, because even in the best cases of breast cancer that comes up to be curable, essentially, we need to continue to have surveillance to look for any chances of recurrence. So it's very important to support not only the patients, but also their families. So we utilize a lot of that support from the get-go in these multidisciplinary clinics. We get our psychologists involved from the get-go, and they are available to our patients if they need it. And then long-term, we have a survivorship clinic here at Geisinger that can help to guide our patients after their treatment in terms of surveillance, not only of breast cancer, but comprehensive medical surveillance, because we know that cancer patients in general are at risk for other cancers, for instance, skin cancers and that sort of thing. So we want to make sure all of their concerns are being addressed. Also, our genetics team can also provide a lot of information about ladies that meet criteria for genetic screening, and that can ease a lot of their personal concerns or concerns their families may have about their increased risk. And even if they don't meet criteria for a high-risk genetics mutation, we still have a high-risk breast clinic here at Geisinger, where our ladies that are at substantial elevated lifetime risk of a second breast cancer or even a first breast cancer can continue to follow with our providers for high-risk breast surveillance, which gives them the best imaging options and best clinical exam options available to detect anything that occurs at a very early treatable stage.
And the high risk stuff, that's been an emerging kind of part of this, hasn't it? The way you
Correct.
detect that kind of stuff early.
Yeah, and you know, we certainly have ways to identify people that are at increased risk. And I would say the most easy way to do that is starting that conversation with your primary care doctor, who can take a family history from you. And if you have what is determined to be a high-risk family history, they can refer you to our high-risk breast clinic. They don't even have to know if you're high risk. The referral alone will help to determine if you meet criteria for a high-risk clinic. And we typically define high risk as having a lifetime risk of breast cancer above 20%. And while that is very important, is because you may then qualify for additional breast imaging that you wouldn't otherwise qualify for. Most women begin screening mammograms starting at age 40 every year. However, our ladies that are at increased risk for breast cancer, whether they had breast cancer before, they have a gene mutation or a strong family history, often meet criteria for coverage for genetics testing and supplemental breast imaging, for instance, breast MRI, that we wouldn't otherwise be obtaining.
So going back to something, you talked about the emotional toll it takes on the patients. How do you as a physician deal with the emotional toll it takes on you? Because you're in, as you said, long-term relationships here with patients, and it's not always a positive outcome. So that has to be rough.
I'm glad that you brought that up about the emotional component. So one of the things that attracted me to this field was the fact that for the most part, our breast cancer patients are diagnosed at a very early stage, which is very treatable and very curable. And it is very personally rewarding to be able to give them information and emotional support, walk them through their therapy, and get them a good outcome, because the majority of our patients do excellent. That being said, you're right. We have patients that are diagnosed at an advanced stage, or patients that do have poor outcomes or recurrences, and we work through that with them. Now our treatments have continued to advance from a medical oncology standpoint that have continued to give these ladies much more time than they would have had in years past, and much more quality time. We always try to balance, side effects with overall extending the quality of life, and that's something we balance routinely with our medical oncologists. I think from a day in to day out basis, just being there for the patients and their families and making sure that they understand the robust, social services and support services that we have at Geisinger to try to help them get through their treatment and any complications they may have with group therapy and that sort of thing that we offer. I think there are lots of options for our patients now.
Are survival rates increasing? And I know you can't paint it all with the same brush. There's different types, but in general, is it increasing?
Absolutely. And, cancers that were previously known to be quote unquote more aggressive or have very bad prognoses now are having more and more targeted therapies. And in certain cases, we are getting options for medications and treatments like chemotherapy that we can be utilized before surgery, so that we can actually watch how cancers respond to those medications. And in patients that happen to get what we call a complete pathologic response, or where the cancer completely melts away with this treatment that we call neoadjuvant treatment, we know that these ladies have an excellent prognosis long-term. So these advancements have been astounding over the past few years, and we anticipate further advancements in the future.
So I have to ask, because we are in very unique times, and I saw an article about this recently. What kind of role has the pandemic played in treatment of breast cancer? And I read somewhere that mammograms had dipped, but have begun to rebound. Has that been the case at Geisinger as well?
Absolutely, and that's a good question, because our priority is always making sure our patients are safe. That being said, if somebody has a cancer diagnosis, we have to expedite their treatment. Now, we have different treatment options during the COVID pandemic that we may not have utilized before. That being said, these treatment options are not experimental. They're tried and proven pathways, but there are options that can minimize patients' risks of exposure, essentially keep them out of the hospital as much as we can. So particularly if a lady presented at any time during the pandemic and currently with any breast concern, we are seeing them. There is no delay. They are able to get what we call a diagnostic mammogram or any diagnostic imaging. However, you were right. There was an overall dip in what we call screening images. So ladies that had no breast concerns and were just coming in for their typical annual visit, those were delayed or put off. But there were some screening images that were rescheduled in order to minimize patients' exposure during the COVID pandemic. Now, however, to the best of my knowledge, we have caught up on those rescheduled images, and we are booking everything just as we were before the pandemic at this time. In terms of surgical treatment, because again, many of our breast cancers are diagnosed at a very early, very treatable, very curable stage, rather than going straight to surgery like we would typically do in many of our patients, we did offer them options to postpone surgery by the use of what we call hormone therapy or endocrine therapy that we know will start to treat the very good prognosis, estrogen receptor positive, early stage breast cancers at that time, and allow women to wait typically anywhere between 3 to 6 months before going on to have their definitive surgery. So for some patients, that was a really good option because if they were high risk, they were older or had other medical comorbidities and didn't want to risk having to come into the surgery, have any sort of general anesthetic or be intubated or stay in the hospital, we opened up other options for them to try to minimize their risk.
So we all have to be careful during a pandemic. How much more careful does a breast cancer patient need to be?
Yeah. I would say in general, we counsel our breast cancer patients to take the normal routine standard precautions. And if they do that, they're typically going to do very, very well. The trickier part gets into our patients that are having chemotherapy. So any of our patients on chemotherapy, I do typically ask them to defer those questions to their medical oncologist. And from working with our medical oncologist, most of the time, again, they're just recommending our general routine precautions of hand washing, masking in public, avoiding large social gatherings, and that sort of thing. That being said, those recommendations could change based on a specific patient's cell counts during treatment, during chemotherapy in particular. So I would defer those specific questions to them. That being said, we do want to encourage the general precautions in terms of our patients moving forward, even with a cancer diagnosis, of getting flu shots and that sort of thing this fall.
So when then, Dr. Sharp, what is your main message for this October?
So, many women are aware that it's Breast Cancer Awareness Month. And I think this year it may be harder for some ladies to get in to see their primary care doctor or get in for their annual screening mammogram. And as I alluded to, we are open for annual screening imaging, and we would encourage any woman to take advantage of updating any health maintenance studies that they may have let lapse over the last 6 months or so with the pandemic. So in this Breast Cancer Awareness Month, I would encourage them to continue their self-breast exams, to reach out to their primary care or GYN to get an updated clinical breast exam, and ask themselves when their last mammogram was. If it wasn't within the last year, or if they've developed any new breast concerns, I would encourage them to update that screening study, because that's really their best chance of finding anything at a very early, very treatable stage.
Okay, Dr. Nicole Sharp, thank you very much for your time today.
Thank you, Chris.
Okay, and we will be right back.